I'd like to welcome back up on stage Dr. Emma Duignan. She needs no introduction because she's already done that a few minutes ago. So Emma, you're very welcome to the stage. Emma's going to say a few words, and we hope there'll be a little bit of time for some more questions. Emma loves questions. The harder, the better. It's a bit like a quiz show up here. So Emma, take it away.
Thank you, Neil. So what I'm going to talk about today is actually pretty practical and applicable to everyone who has a retina, so everybody, and the AMD. There may be a couple of things about eye health that I'll mention for specific diseases, but I'll signpost those. So basically, what are the things you can do for your own eye health, and what are the practical things you can do? I started with the easiest one if you don't smoke already, smoking. So smoking is bad for the macula. We know that because in trials it showed that people who smoked were 3 times more likely to develop AMD. We think the reason is multifaceted, but it reduces the effectiveness of antioxidants at your macula, probably depletes lutein, a very important vitamin that helps sight at the macula, and it reduces blood flow to the choroid. When you're a smoker, your blood vessels get blocked up and you don't get as much blood flow into the eyes. So that's very important. The next thing about is diet. So another lifestyle factor we all wish we were better at, including myself. But specifically when we're talking about the eyes, actually the bad, in inverted commas, things are all the same things really as for your heart health. So things you know about already. If you have healthy blood vessels, which is connected to the heart, you're less likely to develop diabetes. You're going to have a better oxygen supply to the eye. Specifically for the macular health, green leafy vegetables are very important because they contain these things called lutein and zeaxanthin, special vitamins that are very important for macular health and seeing in the center of your vision. The macula is the central vision. Dairy contains vitamin A, beef, liver, it's one of the specific things they mentioned, but also a source of vitamin A. Fish oils for omega-3 is another thing. And then nuts and seeds, sometimes you hear about supplements for AMD. A lot of the things in the supplements, MacuShield and that kind of thing, MacuShield Gold, can be found in nuts and seeds. So that's both vitamins and minerals, vitamins B and E, magnesium, calcium, zinc, all of those things. So I'll come back to inherited retinal degenerations and the supplements in a moment, but in the large trials for AMD, a lot of patients, it was actually only the patients who had a poor diet that benefited from the supplements. People who had a good diet to begin with didn't notice much of a reduction in progression of risk of AMD. So the supplements, if you have a bad diet, are a good idea, but you don't necessarily need them if you do have a well-rounded diet. Just to talk about vitamin A specifically, because there's a couple of facets to this. In retinitis pigmentosa, vitamin A is a good thing to be looking for from your diet. At certain stages in the past, doctors advise people to take high doses of vitamin A. It's not really common now. It was shown in the past in some cases to reduce the progression of retinitis pigmentosa, but it was a bit ad hoc. It didn't seem to be based on the genetic defect that you had. And then high levels of vitamin A can be quite toxic to the body, causing bone thinning, liver damage, a whole range of things. So it's not something we routinely advise, but looking for sources of vitamin A in the diet is a good idea. Then on the other side of that, Stargardt disease. Vitamin A there is a bad thing. And the reason for that is basically vitamin A is used in vision. It's kind of like a tool that you use in the workshop, and then it's thrown away as waste and it's recycled. And in Stargardt disease, ABCA4, the gene that's problematic and the protein it makes, it's called a flipase. And it's basically, I think of it as, you build up these fatty deposits, and the flipase is the thing that kind of shovels it out of the cell. And when you don't have the shoveling, you've got a buildup of toxic vitamin A deposits. So you don't want to contribute to that. So what we'd basically say is don't take anything with vitamin A supplements. And you don't have to avoid it in your diet necessarily. So supplements, including the AREDS 1, you might see some of the eye supplements that you get in the pharmacy can have vitamin A in them, especially AREDS 1 had beta-carotene. That's the age-related eye disease study. That was a large study in the States. That it was for AMD, and they had lots of different things in the same supplement that showed it reduced progression of AMD to the more advanced types. Now, in AREDS2, another big study, the most recent one, they took out beta-carotene. So they took out the vitamin A. So if you are looking for a supplement that you like to take, it should be AREDS2 based, and you can find that online, and it just has no vitamin A in it. And there's actually a very good leaflet about vitamin A if you want to know more on the Stargardt's Connected website, written by Rosie Gilbert in Moorfields, and it's really beautifully written for patients. So we talked about the AREDS supplements, and certainly people ask about that a lot in the clinic for non-AMD patients. Should I be taking supplements? Again, similar to AMD, if you have enough in your diet, you don't need the supplements, but we don't think it's going to harm the retina. So if you'd like to, that's no problem. Exercise, you know, it's a funny thing. Some American physicians who see patients with retinitis pigmentosa prescribe exercise, because there's several mouse models that have shown that the progression in retinitis pigmentosa is slowed when you do exercise in the mice. So I don't necessarily give prescriptions for exercise, but I think it is something that definitely is important to do with any eye disease, and if you don't have eye disease. And obviously one of these things as well that I wish I did more myself, but so aerobic exercise is very important. Sunglasses is another thing that people ask about a lot in the clinic. And certainly if you have a retinal condition, including AMD and the inherited retinal degenerations, UV light we think is toxic to the retina, and very, very slowly may contribute to progression. So we'd say on sunny days, whether it's the summer or the winter, you know, have sunglasses on with good UV protection. And then what is good UV protection? It should have a CE mark, you know, the Communauté Européenne. It's a mark from the European Union that shows that something is of a certain standard, or else it says UV 400. That's another thing. People ask about polarized lenses. They don't have to be polarized to protect your eyes. So that's one thing, because polarized lenses can be expensive. And then, is there any point at all? They do reduce glare, and glare is a very common complaint to people with retinal degeneration. So it basically blocks out horizontal light, not vertical light, horizontal glare. So I do think polarized lenses, there's something to them, and they can make you more comfortable, but they won't. It won't damage your eyes if you don't get the polarized ones. And then a final note about the sunglasses, obviously if they wrap around a little bit, that's more full protection for the eyes. The last thing I wanted to talk about with regard to eye health, because I think the eye can't be looked at as separate to the body, and I think that's mental health. And I think you know, the pain that you feel in retinal degenerations isn't in your eye, it's kind of in your soul, for lack of a better way of putting it. And I think, you know, there's so many supports around that this is something that you have to take note of, because a high proportion of people, you know, I looked up the statistics for retinitis pigmentosa, for example, and there's so many studies that the numbers mean, I think, little, but one of them said that up to 45% of people would have moderate to severe symptoms of depression at any stage. So you have to acknowledge that. There's great supports. You can tell me, the ophthalmologist, your GP. Fighting Blindness have an excellent counselling service that they've had the whole time I've been involved with them, and you know, I've heard such great things from it. That's also run through the NCBI, and I think I wanted to end my little talk here on an anecdote, and that is that I think, you know, the NCBI, I've heard patients refer to their counselling as bereavement counselling, because it's the grief of the loss of some of your vision. And I think, you know, I looked up the stages of grief. We've all heard the 5 stages go from denial to acceptance. And since my first interactions with patients in 2014 with these specific disorders, one of the things that stood out to me is how people go through a journey. And one patient I saw recently, who I saw her initially in 2014, and she was angry, and she had every right to be, because it's a really difficult thing to come to terms with. And actually some of the things she said about her initial meeting with other doctors hit very home to me, and I've taken a lot from that, and I've really tried to make sure that people's first instance with me is as positive and helpful as possible, because I think that is extremely important to your journey. But my main point is that I met her, you know, this year, and she was just so happy, and I think she was in that acceptance phase of the visual loss journey. And I just want to say, if you're struggling at the moment, that I think that is the future of your journey, and I think, you know, things will get better, even if the vision doesn't necessarily get better. And so, you know, there's so much going on here with cures and therapies and everything, but, you know, just as things are, it will become better for you. And I, along with Fighting Blindness, your GP, our eye clinic liaison officers, everyone in the hospital, we're there for you anytime you need us.
Thank you very much, Emma. We do have a question in. It's come from online, so I don't know who it's from. I'm going to try and read it correctly. It said, initially, when retinal supplements were brought to market, it was contraindicated to smoke. Does that still apply?
Yeah, so that's... Oh, is it working? Yeah, that's interesting. So AREDS-1, so this is this large study with over 4,000 patients in America. The initial study had beta-carotene in it, and I explained that they took that out in the second rendition, AREDS-2, and that was not because of Stargardt's patients, it was because beta-carotene was associated with increased rates of lung cancer in current or former smokers. Yeah.
Thank you very much. Any from the floor? We've roving mics, a hand in the air for Emma. Down the far end. Thank you. The gentleman in the rust jumper.
Yeah, the context is my wife has a detached retina and has had 3 unsuccessful operations, so that the sight is now gone. It's 4 very quick questions on that. I was talking to somebody else during the break about a different eye ailment, and they'd been to various specialists who had said one thing or another, or indeed in one case that he was making it up. And then I think apparently what helped was to know exactly what genetic footprint the patient actually had, which zoned in exactly on what the problem was. So that, I suppose, is part of my first question. Would that be normally done if somebody has an eye ailment? Is that their genetic footprint is assessed to help an exact diagnosis? This is purely from ignorance, my own ignorance. Secondly, we've come through COVID. Is there any evidence of other drugs' influence on an eye ailment? As in, my wife had no previous element, and another gentleman I know was talking about retinal detachment and no previous history, of which she has had none, family has had none. A very fit, active person, and then just this arrived out of the blue, and 3 unsuccessful operations. Now, as it happened, she also had cancer the year before that. So between COVID drugs, cancer drugs, and certainly the eye treatments were drops. They weren't actually injections or things like that. So was there any evidence that all those intertwined drugs, I know COVID is relatively recent and new, it's kind of appeared from nowhere, that might have an effect on somebody who has no previous history? The third thing was mentioned there about Luxturna. I think I had it down as Noxturna, but Luxturna?
Luxturna, yep.
Luxturna, the drug, on trials. Would that be any benefit to somebody in my wife's case who's had detached retina and it's kind of like a done deal? The treatment has happened, there's nothing more can be done. Is that of benefit subsequently? And I'd be glad to know the last one then. The clinical patient management system for Europe online, if the case is particularly difficult and if the operations are not working, is that normally accessed to help, as in with all the brain power around Ireland and around Europe, saying, why is this not working on this person, and not working again, and not working again? So those are my 4 questions.
So Luxturna is for people with a very specific genetic defect, and we think there are only about 10 people in Ireland that have it, and it presents in a way that would not be consistent with your wife's history. So I think that wouldn't help, unfortunately. Retinal detachment in isolation in one person in the family without a very strong family history, like the other gentleman, probably wouldn't warrant genetic testing. Although, because because retinal detachments are unfortunately very common, and the more relevant risk factors there are usually short-sightedness or just bad luck. Everybody, once they hit their 60s or 70s, the jelly in the eye kind of pulls off the back of the eye, and sometimes it causes a tear which leads to a detachment. Retinal detachment surgery often fails, even in the very best of people. They talk about their redetachment rate, the vitreoretinal surgeons, and I think in the best of places it's about 10% of eyes redetach. In fact, 20% after the first surgery and 10% after 2 surgeries. So it is less likely, so it's probably 10% likely that your retina would become detached for a 3rd time, but it is not uncommon, unfortunately. Although the CPMS is not being used in clinical practice yet in Ireland, I know from our own vitreoretinal surgeons in the Eye Near Hospital, I am not a vitreoretinal surgeon, but I know from their practice that the key thing would be if they were having, now redetachment is part of their usual practice, unfortunately to say, but if they had a case where they had difficulties, everyone in Ireland in ophthalmology generally trains abroad for the last couple of years of their training, and they often talk to the people at their Centre of Excellence in Europe or the US if they're having difficulties. So although the CPMS is not officially open to us yet, informally, almost every surgeon uses an informal network to, I know my husband's a VR surgeon and they have a WhatsApp group. That's how they get in contact. So certainly international expertise is being used in an informal way already, and the CPMS will formalise that, but it's not something you have to worry about that it's not a thing yet. No problem.
Thank you, Emma. I've got 2 online. I think these might be quite quick. Does alcohol badly affect RP? Should it be avoided?
The answer is no.
I'm asking for a friend.
So, yeah, no, we don't think alcohol affects the retina too much. Obviously, it affects the other parts of your body, and I think it can contribute to slightly earlier development of cataract. But compared to smoking, there's just nowhere near the same evidence, so no.
The next one is, do preservatives and additives in food have a negative impact on RP?
So that's an interesting question from the point of maybe the Stargardts more. So I think in RP, in general, they talk about preservatives and fresh food is better for heart health, cardiovascular health, and preservatives, trans fats, all of these things that we worry about. There's actually a cardiovascular disadvantage to those things, and I think that's the way in which they may affect RP health negatively, because obviously if you have RP, you need the blood vessels even more to provide the oxygen to your retina, and that is something that a lot of Natalie, who you met before's work, is based on. But getting back to the Stargardts, which is an interesting thing that I was reading about, and I don't know if this is practically, I think you have to balance all of these things. You can't be worried too much about the food, but that Stargardt's Connected leaflet I read for patients, which was very good, interestingly mentioned that you should avoid the likes of fortified foods. So the way some of the breakfast cereals, they may have vitamin A in them. It's just something to be aware of. If something does say it's fortified, has extra things in it, just to make sure it's not vitamin A. But I wouldn't be too obsessive about that. You have to kind of live your life.
Thank you. I think we have time for one more in the room. The lady down here, please.
Yes. Hello. Dr. Duignan. 2 questions. The first one, I listened with interest to Dr. Keegan speaking about the future trials that are going to happen in Dublin and Ireland for AMD and other retinal diseases, but he never mentioned RP. Where are we in relation to RP trials?
I suppose because RP, I think it's become very specific now, because a lot of the therapies are related to specific genes causing RP. RP is caused by over 80 genes that they've identified now. So actually some of the genes he mentioned were forms of RP. USH2A is one of them. And actually USH2A is the most common cause of recessive RP. So that'll be a large number of people. He mentioned CEP290, and that causes a very severe form of RP that affects children. So, oh yes, and RPGR, these are all just names of genes. That's why it was maybe slightly misleading that RP wasn't addressed, but definitely was. So the RPGR trial, which is the most, the one that's closest to fruition at the moment, is a form of X-linked RP. So actually that a lot of the terms he mentioned there did relate to RP, just the specific gene causing the RP. So definitely that's probably the biggest group on the table.
Well, my gene has been identified for RP, but I've never heard back from my clinician about a trial.
Well, I don't think he's at the stage, or we're at the stage of contacting people for the clinical trials yet. Yeah.
Oh, I see. Thank you.
But certainly, if you're wondering, there's no harm in sending an email or giving us a call to just check. There's no problem. You know, what I certainly want from the service is for it to be accessible, because people come with questions all the time, and we're happy to answer them on the go, you know.
And finally, what about acupuncture? Is there any scientific evidence that it can help RP?
I don't know of any scientific evidence that it can help RP, but I don't disbelieve that acupuncture helps some things in general. I think there are some very strong clinical proponents of it, doctors who perform it in some cases. So I don't know any direct trials for acupuncture in RP, but I would in no way dismiss it.
Okay, thank you very much.
One more online question. Because it relates to, are there any clinical trials for patients with RP-LCA currently?
So LCA, there's one called Illuminate. So I think it actually is finished now, but it was for an Leber's congenital amaurosis caused by the gene CEP290. And it was, one of the great things about it was injectable. So some of the gene therapies are subretinal, so you have to have a kind of a bigger surgery, take all the jelly out of the eye, and then inject underneath the retina, which is a bit of an involved procedure, but this was an intravitreal injection, a bit like the ones you have for wet AMD. Unfortunately, it failed to meet its primary endpoints, but it's just the beginning. It's really exciting. So I think that's the only one I know of currently, a large clinical trial, but there may be some others.
Dr. Emma Duignan, you've scored 16 points with no passes.
Thank you.
Okay, so one more. For that 17th point, Dr. Emma.
Okay, Gerda, there's the microphone. There you go. Thanks.
I had gone to the eye and ear research last year. I had stopped going. I'd stopped going to see about my sight because it always, I've RP, and it was always, come back the next year and blah, blah. And I didn't have anything happening. But when I did go to the research department, somebody was suggesting to do that, he put a whole lot of drops in my eyes. And then when I was going home, I couldn't believe it. I could see so much better. And you know the way when they say go to the hospital, be careful when you're going home and so on, because your sight is going to be blurred. Well, my sight was not blurred. I was actually I had my dog and I got onto the bus. Somebody told me what the number of the bus was and so on. But I couldn't believe I could see the houses. And I could almost make, I could make out the doors and the windows. And I rang up the next day to the specialist, and Paul Kenner, is it? And said, look, I need more of those drops, because I could see better with them. But I was told that, no, they would damage my eye. And I thought, for goodness sake, anyway. Anyway, I did get, at least at that time, he told me to go and find out about getting the cataract removed. And I'd been told, 20 years ago that if I'd had the cataract removed, I could lose the sight in that eye. In fact, I could lose the eye altogether. So I said, forget it. And, the little bit of sight I have with it, I'll keep that, because the other eye didn't see at all. But then when the sight was getting worse and worse and worse and worse, I finally decided to take the chance, because I might as well, because I could only see the lights. And now I can see the windows, I can see people. I can't recognize their faces, really, but I've got a lot of useful sight, and I can actually see the notice when I was closer up of fighting blindness there, and cures and whatever. The 3 different things, I can't remember them now. But literally, I don't know, I'm so grateful to the fact that I can now see a bit and I have some useful sight, which is far better than having no sight at all.
Wow. Well, that's a lovely story and definitely a success story for cataract surgery. And certainly, even in the past 20 years, cataract surgery has gone through many phases and has been performed in completely different ways at different stages. So you were probably 20 years ago in the early stages of phacoemulsification, where we did everything really with an ultrasound probe, and it's become safer and safer and safer. So it's a very, very common surgery now. It has a very high success rate and a very low complication rate. So I think even if there's just the chance of improving the vision, I think a lot of the time, and if it's visually significant, looking at the cataract, sometimes you can say, you know, some of them aren't in the center and they're way off there, and maybe it's not, it's always a balance of risk and reward, but it is something that you don't have to be too concerned about. And if there's a small chance of better vision, I think you were right. It was obviously the right choice you made to take it.
30 years ago, I had the right eye done, and I've lost the sight in that eye. So I wasn't bad to lose the sight in the second eye.
Yeah, well, I think in the past, in the beginning, about 40 years ago, I'd say, you know, the last consultant who retired said at the beginning of his tenure, cataract patients used to stay for 3 weeks. And you'd basically open up half of the cornea and there were no sutures to close it. So they had to lie there with almost like a man in the iron mask grid over their thing and over their eyes and sandbags on either side so you didn't move your head. And you stayed like that for 3 weeks. And now you know yourself, it's 20-minute procedure and you stay for 2 hours. So
No, my eye actually flared up and was all red and so on for the first operation, but I had no problem with the second one.
yeah, it's a totally different surgery now. So good one to go for.
Sorry, ladies and gentlemen, we do have to move on.